Welcome back. This is going to be Cardiopulmonary Diseases, Chapter 14. We're going to talk a little bit about asthma tonight. And here's some just key information about it. As you can see, in the Bronx, children with asthma have like 1 in 4, which is triple the national average. There's the bronchial during an asthma exacerbation. And then there are different triggers, and we're going to talk about some of these triggers as we go through them. So there's updated guidelines for asthma. They're developed, disseminated on a regular basis, both by the National Asthma Education and Prevention Program, and you're going to see on here too the Global Initiative for Asthma related to the Global Initiative for Chronic Obstructive Pulmonary Disease. The American Lung Association is also part of this. The Expert Panel 3 report is fairly recent, and if you want to take a look at it, it'll tell you some of the major changes that are coming through how to manage asthma. You see the first evidence-based guidelines were published in 1991. So asthma had been around for a long period of time before we ever got these guidelines. And the definition of asthma basically is a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role. In particular, the mast cells, if you remember, in pharmacology, we talked about cromolyn sodium, which is a mast cell inhibitor, eosinophils, the T lymphocytes, macrophages, neutrophils, epithelial cells. The IgEs are also in there too, and it just depends on basically what type of asthma, where the asthma is occurring at that point. So the guidelines, as you can see, are structured around 4 components. One is assessing and monitoring asthma. We need to teach families how to do that. We need to teach the children how to do that, if they're old enough to be able to do that, how to use their peak flow meters. I know you did those or talked about those with Therese as far as that goes, how to determine when they're in trouble and where they need to get help at this particular point. And that goes with number 2, which is patient education. Constantly educating, this is what you need to do. One of the major things we're going to see as we go through this is an asthma action plan. And an asthma action plan is something that you're going to do that tells you if you reach a certain level, this is what you need to do. If you reach down to another certain level, this is what you need to do. This is so that you can take care of yourself better, and we can help you with that too. We also need to know what causes the asthma. Is it intrinsic? Is it extrinsic? If it's extrinsic, you look at any of the literature, they'll tell you things like don't have carpet, don't have animals in the house, or if you have animals in the house, don't have them in the bedroom. If it's mold and mildew, make sure you use a dehumidifier, different things along that line. So we have to take a look and see what goes on. And then we need to know what kind of treatments we have. A number of new treatments have been added. You saw that when you took pharmacology. There's lots of them. We have the monoclonal ones that we're using now, and they're working well too, but you have to be able to test the folks and see if these are going to work for them. And as far as GINA, it came in 1993, a couple of years later, out of the NHLBI at this particular point in the World Health Organization. They published guidelines. They have them in 2018, 2019, and 2020 is the latest one. If you go online, you can see what they are. Their goals are basically a little bit wider ranged than the NAEPP. In these cases, we want to make people aware of what asthma is, and we want to know what people know what the consequences are. What is the cost of asthma? Not only in monetary amounts, but in days missing, work missing, being missed, school being missed, and the overall effect that it has on the family and on the community. And then we want to know, why is there increased prevalences of asthma? Has the climate changed? We're now starting to link climate change with asthma. One of the folks who was a big mover and shaker in this field came from New York, and one of the things that he researched was cockroaches and asthma, and he found out there's a tremendous problem with asthma when you have cockroaches in your houses. And so that's something that we have to work with. Can we keep the areas clean? Can we get rid of these varmints before they cause problems? And then, as I said, between asthma and the environment, remember climate change is affecting this. We know that when the climate changes, people who have asthma, a lot of times, just like folks who have rheumatoid arthritis, they can tell you there's a storm coming. They can tell you something else is happening at this point because it affects them. And if they're aware of themselves and they're aware of that, they know how to take care of themselves. Another one, want to reduce morbidity and mortality. Unfortunately, asthma has been on the increase. Unfortunately, a lot of folks don't understand that. A lot of people are like, well, asthma is just all in the minds of the beholder. Yeah, until you see somebody who's in really bad shape, that's not what you're going to believe after that. How do we manage it better? Do you have the money to pay for what you need? One of the big problems a couple of years ago, if you remember, was folks who were taking Xolair. They had to carry an EpiPen with them, and those EpiPens were costing up to $700. A lot of people couldn't afford them. Their insurance companies weren't paying for them, or they were only paying a very small portion of them. And so people had to stop and had to go off of that. And then they went back to the asthma exacerbations that they had suffered before then. The newer monoclonials, those are not cheap drugs either. And if the insurance companies aren't going to pay for them, they may work beautifully. We can give you samples, let you try them, but if you can't afford them, unfortunately, you can't continue with them. And what they found out is if you can work together, which these guys do, and you can get the folks involved in the community, much, much better as far as that goes. We had a really good presentation this year from a young man who's a respiratory therapist. He's up in Page. He's working on the Navajo Nation up there. And they got with the president of the Navajo Nation, and they've really done amazing things to have the community educated. One of the things is that they actually have the students or children are allowed to have their asthma inhalers in school. A lot of the schools, they have to be in the nurses station, and the students will not go down there to use them. But because there is a place in the law that says that these students can keep their medication with them, they have push that, and the students do have their medication with them. And now they can use them when they need to. They don't have to go to the nurse's station. They also redid, which I thought was just wonderful. Okay, so some of the other things they've done is they've done some of the have done the reposters so that they represent the community much better. So they've done a lot of work for it, and as a result of that, I think things are going to get much better. This is just a nice picture. As you can see, there's some eosinophils. Remember eosinophils. Interesting thing, some of the research they're doing now is on the IgEs. Remember that was one of the answers in the pharmacology questions about, what is first attacking for asthma, and it was IgE or eosinophils. Well, IgEs have a very specific role, and they respond to allergic asthma, whereas eosinophils are on the bronchial walls and they're more widespread. So what you're looking at here is the eosinophils, and you can see how big they are at that point. And then the Charlotte Leiden crystals are another one too that you can see. Once you see those in your sputum, then you know that you do have some asthma. So it's been around for many years. A most common disease that we find in clinical medicine. And as you can see, it has increased. It's increased not only with kids, but with adults too. You can see there's over 500,000 Americans hospitalized annually for severe asthma, and about 4,000 will die as a result of their asthma. And the unfortunate thing is a lot of them will die at home or die on their way to the hospital simply because they waited too long before they asked for help. The CDC figures there's 10 Americans every day who die from asthma, and adults are 4 times more likely to die from asthma than children, women more likely than men and boys, and African Americans are 3 times more likely to die from asthma. And a lot of what we see is connected with poverty, the city air quality, indoor allergens, not enough patient education. I'm going to add to that also family members not taking to heart the patient education, and their kids not following either. And then poor health care is another one. And the thing that's kind of interesting is the highest ethnic group, or the ethnic group with the highest rate of asthma and its consequences, is actually in Puerto Rico. And there you can see the cost of asthma. Um, Economic cost over $81.9 billion, and that's your medical costs, loss of work and school days, and it's broken out for you. Annual per person cost was like $32.66, and it's one of the main reasons why children miss school days. So what happens with it? You see a lot of bronchospasm with it, bronchial wall inflammation, and bronchial edema. We know this is caused by the eosinophils. You have an excessive production of thick, whitish bronchial secretions. That's one of the hallmark signs when people talk about looking at x-rays and seeing the flattened diagrams, the air trapping and all of that. But they tell you that the person is coughing up white secretions. They're not talking about COPD. They're not talking about emphysema or chronic bronchitis. They're talking about asthma at this particular point. They can have mucus plugging. One of the things that you have to watch with the mucus plugging is you don't want the mucus plugs growing. And so one of the things is if someone's having a problem with their asthma, one of the things that they want to think about not doing is taking a hot shower, because what that extra heat will do is cause those mucus plugs to grow. And if they're starting to grow, then they're going to go ahead and block the airways. Basement membrane will become thicker, and as a result of that, they have airway remodeling. So risk factors: extrinsic asthma, this is allergic or atopic asthma. These are something outside of the body, clearly linked to specific allergens or antigens. House dust is a big one. Mites is another one. As we talked about, the animals, cockroaches, fungus, molds, all of those different things. And then sometimes food and drug allergies go with it, and the respiratory infections. And there you can see some of the triggers: the mold, the smoke, chemical odors. And one of the things is that sometimes parents will sit there and tell you, yes, I'm still smoking, but I'm not smoking around my child. I'm driving down the road, I have my arm stuck out the window and my cigarette smoke is going out the window. Yeah, but you're bringing it back in. Your head's not out the window when you're smoking. And the other one too is they'll tell you, well, I'm putting on a shirt over the shirt I'm wearing, or I'm just going out to step out to do it. When you come back in, especially if you bring the shirt back in or you're wearing the shirt, you brought that smoke back into the house also. Host factors: your genetics, obesity, and sex is another one, males versus females. Occupational sanitizers. Some people react negatively to bleach and things along that line. Tobacco smoke before, and especially if you're smoking, if the parent mom is smoking before the child's born, sometimes the child will end up with asthma. And then your diet too. What are you eating? Because there's certain foods that will trigger it. And that's kind of a cool picture. One that people don't think a lot about: emotional stress. When we were on campus, we would see that on occasions. We would have to go to the ladies' room and somebody would be in there wheezing and and not being able to breathe. And you'd ask them, what's going on? Could you breathe? Fine, fine. And then we'd end up calling 911. They would come and evaluate them. Sometimes they would take them back to the hospital. Some other times they would let them take their medication and they would feel a little bit better. And then if you asked them what was going on, a lot of times it was, well, we had a test today and I'm not ready, or my boyfriend and I got into a fight last night, and and they just couldn't handle it, unfortunately. And there you see some of the constriction that goes with it, and the cute little mast cell up in the corner. Other things, drugs, people do have a reaction to drugs. People who have asthma sometimes are unable to take drugs or else they'll develop a sensitivity or an allergic response to them. Food additives, especially the dyes, are pretty bad. And some of the preservatives, exercise-induced bronchoconstriction, we see that with kids when they're playing baseball in the summertime too. That's why they have to go on chromium sodium, things along that line. GERD is a big one. They do a lot of research on that one, and they found out that people who have gastric reflux at night, it goes up and goes into their lungs, and because it's going into their lungs, it's causing them problems with their asthma. And there's your emotional stress. Perimenstrual asthma is kind of an interesting one, because if you talk to some females when it gets around time for their menstrual cycle, they can tell you that because their asthma begins adding up for it. And then aspergillus is one that we see both here with asthma and with CF. And you can see extrinsic as an anaphylactic hypersensitivity, family related, it appears in children and adults younger than 30 years of age, and it can, a lot of times can disappear. Unfortunately, it can come back on occasions too. And then sometimes with intrinsic asthma, we'll see that at a much older age. So how do we know, or what do we suspect? Wheezing is one of the big ones. Coughing, especially with wheezing, difficulty in breathing, chest tightness, being unable to catch your breath. The thing about it is, though, and this is where people sometimes get off the track a little bit, people will come in and they'll go, oh my gosh, they have asthma, they're wheezing, you need to give them some breathing treatments. And you're going in there and you're talking to these patients, and it's not asthma, it's what they call cardiac asthma. And basically it's a cardiac response, okay? It has to do with the left heart. And as a result of that, all the breathing treatments in the world's not going to do anything. And so we have to make sure that we keep our eyes open for that. Another one is your symptoms will occur or worsen at night and keeps the patient awake. It's seasonal pattern. We talk about that. Eczema is a big one. People who have asthma have a lot of eczema, and then hay fever and things along that line that go with it. And all that good stuff that we talked about. Aspirin is another big one too. Aspirin is a major one with intrinsic asthma. There's people who are unable to take any of their aspirins, and then sometimes Tylenol will also fall into that category. So diagnostic monitoring, your FEV1, FEC ratio, PEFR. If we get reversibility, I know Therese talks about this, so I know you've heard this before, any increase greater than or equal to 12% or more than 200 mLs tells us that, yes, they do have asthma, and we can reverse it with bronchodilators. And the ratio sometimes is a little bit better than just one single at that particular point. And there you can see with your PEFR, an improvement of 60 liters per minute or greater than or equal to 20% tells us that that's a good deal for us too. So tests that we can use, methylene choline, remember that's a parasympathomimetic that causes bronchoconstriction. Histamine. Histamine is an allergen. Remember, it's released by your mast cells, and that will also cause it. Inhaled mannitol, they're using that, not necessarily here, but I know over in Europe. Exercise or cold air will do it. When you look at TV, if you watch during the wintertime, people that are out walking around have masks over their faces, or they have their scarves or something, because the cold air affects their breathing and they can't breathe very well. And then you can have positive skin testing. If you've ever had that, you know they poke about 200 holes into you, it seems like, and they'll go ahead and see which ones are going to cause you the most problem. They may have to make sure somebody's around to reverse any of the reactions if they get too badly. And then an exhaled nitric oxide is another one. Remember, next we need nitric oxide for vasodilation. And, you know, as long as it's within the system at a ratio where it needs to be, we don't have a problem. But unfortunately, with folks who have asthma, in some cases, what happens, we overproduce it. And when we overproduce it, then unfortunately, what's going to happen is that you're going to go ahead and have some constriction at that particular point. The nice thing about the nitric oxide test, it's an exhaled one, it's FeNO, is that it tells us whether or not you're having a problem with your asthma, and it also tells us whether or not the inhaled or systemic corticosteroids are working as they need to. So it's a pretty good test. There's some places that are still like, yeah, maybe, maybe not. But when it's used with other tests, it's really, really good for helping to diagnose asthma. So there you see challenges in the differential diagnosis. It has to do with children and adults and the elderly. A lot of times we diagnose the elderly with asthma when they don't have it, and we don't diagnose with it when they do have it, okay? One that's interesting, and a lot of folks haven't heard about that, it's called sick building syndrome. Where we see this one is because of the buildings that we're building now. We enclose them really well. We make them very airtight. And then we go ahead and we lay these carpets in there, and we use these paints and things like that. The carpets a lot of times are giving off fumes in addition to formaldehyde. And people go to work, and now because there's no airing out, they'll start to develop allergic responses to it. And there was a story at one time, this was years ago, that there was a gentleman that was working one of the new buildings, and his allergies got so bad he had to quit his job, had to move out of his house, and he basically went and had to live in the desert because that was the only air that was good enough for him to be able to breathe. So here are clinical manifestations. Here's some of the pathological mechanisms that are activated or caused by asthma, bronchospasm, and excessive bronchial secretions. Vital signs, some of these are going to sound like they have COPD, increased respiratory rate, heart rate, blood pressure, a use of accessory muscles. Remember, you can get the air in, you just can't get it out. And so you're having a difficulty because once you get air trapping happening, you would think, oh, well, that's not too bad. You know, you still should be able to take a breath in. It is not that easy. And normally what I have folks do is I'll tell them, go ahead and take a breath, blow it out, but not all the way. Stop, and now try to take another breath in on top of it. And it's kind of hard. People don't realize that. We do on occasion see barrel chest, and on occasions we do see cyanosis, depending on how bad it is, and lots of cough and sputum production with it. Pulsus paradoxus is another one. Remember, your blood pressure is supposed to drop about 5 millimeters of mercury when you inhale, and that's the time that blood returns to the heart. However, sometimes when you're in the midst of an asthma exacerbation, it drops by more than 10 or more, and that's pulsus paradoxus. And because of all that air trapping, you're not going to get your tactile vocal fremitus, hyperresonant percussion node, diminished breath sounds, diminished heart sounds. Does this sort of sound like the COPD patient? Sure does. And the reason is there's a lot of air trapping that happens with this. So some of the clinical data, special test. Here's your PFT information. And like I said, I'm sure you talked with Therese, and she showed you all that good stuff too. You have, as you can see with this, I don't know where chapter 13 came from, but that's okay. But the lung disorder is characterized by reversible muscle constriction, airway inflammation, edema, mucus plugging, all that good stuff. Lots of air trapping. And there's some more of it. Your blood gases, the blood gases for asthma are really, really interesting. I remember when we were working one time, we came in the morning because I was working day shift, and the night shift had come in and they said, oh, Dr. So-and-so from the ED said that she wanted to make sure you guys saw all these ABGs. And what they are is there was a person who had come in who had asthma, and they were in the early stages of asthma. And as a result of that, their blood gas was an uncompensated respiratory alkalosis, and they had mild hypoxemia. When they started to get worse, the blood gas, when you did it, was now a normal ABG with worsening mild hypoxemia. And then when they slipped over into the worst end of it, their ABG then became uncompensated respiratory acidosis with moderate hypoxemia and headed towards severe hypoxemia. People who don't deal with people who have asthma think that once they hit that normal middle ABG that they're getting better, and they're willing to say, oh, just give them some inhalers, we're going to send them home. And when that happens, when they're brought back, most of them are dead. This is one of the reasons why you as the respiratory therapist and you as the patient advocate need to be sitting there going, you don't want an ABG on them right now to see if we are getting worse. But if you listen to them, you can see there's a lot of air trapping, hyperinflation going on. They're still using accessory muscles, and it's actually gotten worse. Their heart rate is much, much higher, as well as their blood pressure. I don't think this person's quite ready to go home. So you have to be that patient's advocate. And there you see the respiratory acidosis. So you can look at the sputum. There's the eosinophilia, those crystals we talked about, the Kirschmann spirals. If you look up the spirals, you'll also see them spelled Crushmann, but they're basically the same. And there's your IgE levels elevated in extrinsic asthma. And like I said, the eosinophils are elevated when it comes to bronchial wall inflammation, more widespread than just extrinsic asthma. And this is a cross-section of lung from a person with asthma, which was a major obstruction of the bronchi. And you can see, look at that hyperinflation going on in there. And then how do we tell the difference between asthma and COPD? Because when you look at the new diagrams that have come out that talk about asthma and COPD, you'll see that they have chronic bronchitis, emphysema crossing, and then asthma is at the bottom part crossing in there too, because some of these people also have asthma. But these are the different things that you can use to see, what do we have at this particular point. And this is something that I would probably make sure that I had a copy of it. So then when I went to clinical, I would have it. And if you're going to become an asthma educator, this is also another good thing to have with you. So with the chest radiograph, there's your barrel chest, the dark fields because of all that air trapping, and depressed or flattened diaphragms. And this, as you can see, this is a 2-year-old during an asthma exacerbation. You can see the diaphragms, in fact, are fairly flattened. And look at the blackness of that x-ray. It almost looks like it's overexposed. This is a normal hyperinflated lung. The problem with this is the patient died of status asthmaticus. Status asthmaticus is when we've lost the battle, okay? And basically what it is that we were doing everything that we could to try to reverse for this patient. They could have ended up on CPAP BiPAP we're going to talk about. They could have ended up on high flow nasal cannula. They could have been intubated, put on a ventilator. Unfortunately, they were too far into their disease at that particular time, or something else came and happened at that particular point, and it just went to the point where there was no way that we could reverse them. Pretty lungs, though. And this is the hyperinflated lung of a patient who's in the process of dying. You can see how big those lungs are. So how do we manage asthma for the most part? You got to get control of the information that's associated. Figure out what you're doing. One of the things you have to sometimes when you're talking with patients, especially some newly diagnosed patients, they'll tell you, I don't want to do this. I don't want to set this off. I'm really afraid to do this. I'm really afraid to do that. The question is, do you wish to control your disease or do you want your disease controlling you? If you want your disease to control you, you're going to live a pretty poor life because you're going to be too afraid to do anything. If you're going to control the disease, then you need to get as much education about this disease as you can. You need to be able to discuss this with your physician or whoever else that you're working with at a clinic or the hospital. You need to figure out how to maintain your normal activity levels. How far can you push it? You've got your peak flow meter. Take that with you. The thing is a lifesaver. It'll help tell you when you're having problems. It'll tell you when you need to do what you need to do. And then you need to be smart about what you do. So these are the general management of asthma, the components of it. Biggest thing is you've got to make a partnership with the physician. Okay, this is the parents, these are the kids. The kids are too young sometimes. It's so important that we get these parents on board, that we educate them. You don't scare them. Oh my gosh, when he starts coughing, he's going to turn blue. Oh my gosh, you're going to let this happen. Forget everything at this point because nothing's going to be good. So you need to be able to talk with them, become open to them, let them talk with you. You can sit there, and unfortunately, we have people who do this. Oh my gosh, I can't believe how stupid you are. You know, they are not educated. Your job is to educate them. They're not the ones who are stupid. You are because you can't educate them. You have to be able to open up a partnership. You have to be open up a dialogue, okay? And then part of that is looking what caused this. Do you know what caused this? What have you done? If you've been to see the doctor before, what did you guys talk about? What did you think perhaps were the causes for this? At one time, and this is back in Cleveland, some folks from the Cleveland Clinic used to go to these houses of the kids that had asthma, and they would talk with the parents, and they would look around. And I remember they talked one time, this child was reactive to mold and mildew, and his bedroom was down in the basement that had a lot of mold and mildew. And it also had a rug down there. They had to talk to the parents and tell them, I understand you want to honor his privacy, give him, he's a little get older, but he can't be down in that area unless you clean it up and you figure out some way to control the mold and mildew and get rid of the carpet. Okay. And then how do we manage these asthma exacerbations? This is part of your asthma action plan, okay? If this is going on, instead of doing your inhalations 4 times a day, 2 plus 4 times a day, maybe now you have to use them 6 times a day. If you're using them, most of the action plans are if you're using them every 2 hours and you're still not getting relief, you need to be on your way to a clinic somewhere, or you need to be on your way to the hospital, okay? And then anything else that we need to take into consideration at this particular point. So there it is, talking about what we talked about, the partnership, what the common triggers are, how do we treat this? And then the notion of step therapy. At one time, and I remember this, what they basically had said was, when you're having your treatments, you're at this step, and this is the meds you're taking. If things are getting worse, we're going to bump you up to the next step. And then if things get worse, we're going to bump you up to the next step. And if you said, well, can we ever go back down to the previous steps? Nope. Once you have been bumped up, you have to stay there. You never can go back. We now know you can go back. There is looking back. And so we have to be able to explain that to folks. This, just because Johnny had a good day today, though, it doesn't mean that you can go back to where he was. You have to make sure that that good day becomes the next day and the day after and the day after and the day after. And your book talks about stepping back. You have to have good control for about 3 months. And that tells us that you're ready to step back. And this is how the step works and shows you the different drugs and things that you can add at that particular point. And that's just the right out of it. This is a little bit about an asthma action plan, okay? Shows you what's going on with all these kids. And things that we may do sometimes. They have to come into the hospital. We're definitely going to give them the albuterol. We're going to give them some Atrovent. We're going to give them some steroids, systemic steroids. Inhaled steroids are not going to do very much for you until we're able to work with it and make sure that we can get them in. Oxygen therapy is important. And then we'll sometimes use continuous nebulization. When I was working, we never did continuous nebulizations, but our form of continuous nebulization was back to back to back to back to back treatments at that particular point. And this just shows you, here's a algorithm of how to take care of acute asthma exacerbations. And then special considerations, pregnancy will sometimes set it off. Obesity, simply because you can't breathe. We do see a lot of rhinitis and sinusitis and nasal polyps with folks who have asthma. We also see with patients who have CF. So, you know, that's one of those things that tells us, oops, we're on to something here. Occupational asthma, all of those other things that go with it. And, you know, what is the trigger? What are we going to do to take care of it?